Welcome back to the USMLE Sprint. Today, we're breaking down pleural effusion, one of those high-yield topics that shows up everywhere from exams to the wards. Pleural effusion is an abnormal accumulation of fluid in the pleural space, the thin area between the lungs and the chest wall. It's one of the most common pleural diseases and can arise from a wide range of systemic or local causes. Broadly, pleural effusions are classified into two types, transudative and exudative. Transudative effusions occur when there is increased hydrostatic pressure or decreased oncotic pressure, such as in heart failure, cirrhosis, nephrotic syndrome, or constrictive pericarditis. Exudative effusions result from increased pleural vascular permeability, as seen in infections like pneumonia or tuberculosis, malignancy, pulmonary embolism, collagen vascular diseases such as rheumatoid arthritis and lupus, pancreatitis, trauma, or after cardiac surgery. Clinically, patients often present with shortness of breath, pleuritic chest pain, or cough. On examination, there is dullness to percussion and decreased breath sounds over the area of the effusion. Sometimes, a pleural friction rub may be heard. The first step in diagnosis is a chest X-ray, which typically shows blunting of the costophrenic angle. A lateral decubitus view can help detect small or loculated effusions. When a new effusion measures more than 1 centimeter in thickness on the decubitus view, a diagnostic thoracentesis is indicated, except in patients with clear bilateral effusions and clinical evidence of congestive heart failure. To determine the cause, we look at the pleural fluid characteristics using Light's criteria. An effusion is considered exudative if any one of the following is true. The pleural fluid protein to serum protein ratio is greater than 0.5. The pleural fluid LDH to serum LDH ratio is greater than 0.6. Or the pleural fluid LDH is more than 2/3 the upper limit of normal serum LDH. If none of these criteria are met, the effusion is transudative. Let's talk about a few special cases. Tuberculous effusions are usually right-sided and exudative. The pleural fluid often has low pH, low glucose, and a lymphocytic predominance. Remember that reactivation tuberculosis is more common in patients with chronic kidney disease, diabetes, or smoking history. Malignant effusions can also be lymphocytic, but typically have less than 70% lymphocytes. Next, parapneumonic effusions. These occur when pneumonia spreads inflammation to the pleural space, allowing fluid to leak in. Children with small effusions may still appear comfortable, but moderate or large effusions cause tachypnea, grunting, nasal flaring, and subcostal retractions. There are two types of parapneumonic effusions, uncomplicated and complicated. An uncomplicated effusion is a sterile exudate that's small, free-flowing, and not infected. The pleural fluid has a pH of 7.2 or higher, glucose above 60, white cell count under 50,000, and LDH below 1,000. A complicated effusion results from bacterial invasion of the pleural space. Here, the pH drops below 7.2, glucose falls under 60, white cell count rises above 50,000, and LDH exceeds 1,000. The fluid may be loculated, and gram stain or culture may or may not be positive. If the infection progresses further, it becomes empyema, in which pus accumulates in the pleural space and cultures are almost always positive. Pleural fluid glucose is another important clue. A level under 60 is seen in rheumatoid pleurisy, complicated parapneumonic effusion, empyema, malignant effusion, tuberculosis, lupus, or esophageal rupture. When glucose falls below 30 milligrams per deciliter, think of empyema or rheumatoid effusion. The low glucose comes from high metabolic activity of white cells or bacteria within the pleural space. For management, small effusions without respiratory distress can often be treated with oral antibiotics and monitored closely as an outpatient. Moderate or large effusions, or those associated with hypoxia or respiratory distress, require hospitalization, intravenous antibiotics, and drainage. Free-flowing empyemas are best treated with chest tube drainage. If the fluid is thick or loculated, intrapleural fibrinolytic therapy with TPA and DNASE may help break down adhesions. In highly fibrotic cases, surgical decortication may be necessary. Let's take a moment to talk about congestive heart failure related pleural effusion, the most common transudative cause. In heart failure, elevated left atrial and left ventricular end-diastolic pressures transmit backward to the pulmonary capillaries, increasing hydrostatic pressure and pushing fluid into the pleural space. These effusions are typically bilateral, though sometimes they can be unilateral, more often on the right side. About a quarter of patients may appear to have exudative fluid if they've received diuretics before thoracentesis. Now let's discuss pleural fluid pH. Normal pleural fluid pH is around 7.6. In transudates, it ranges from 7.4 to 7.55. In exudates, it falls between 7.3 and 7.45. A pleural fluid pH below 7.3, especially when the arterial pH and glucose are normal, suggests empyema, pleuritis, tumor involvement, or pleural fibrosis. To summarize the key numbers, normal total serum protein is between 6 and 8.3 grams per deciliter, with albumin making up about 3.5 to 5 grams, and globulins around 2 to 3.5. Light's criteria help you decide whether an effusion is transudative or exudative, and the pH and glucose levels help you narrow down the cause. Pleural effusion, therefore, is not a disease itself but a signpost, pointing you toward what's happening deeper inside the body, whether it's heart failure, infection, malignancy, or inflammation. Recognizing the type and the underlying cause is the key to targeted, effective treatment.